Get out page 37 for me. We're going to walk through a case study and finish up pregnancy.
Time since we did the.
Get better in time.
No, yeah, you're right. It is. It's very.
Some of this will be reviewed, some will not. 37. Pregnancy. Amber, who's 18 and now going to have fun. Went to the big city and forgot her thoughts.
Let's see, 5 out of 6.
Okay. Goes to the doctor. Congratulations, you are pregnant 9 weeks. Way to go. Better not be my daughter. So let's review why is she not menstruating while pregnant? The answer is HCG. Very good. Let's come a review question. Human chorionic gonadotropin. Where was it made? Your quiz? Blastocyst, blastula, embryo. Okay? When do you make this hormone? Good. And when is that? So implantation onward. So remember, it starts when the blastocyst implants, which is about week 1, and then it creates from there. So you're going to start making it at week 1, although you can't measure it then, but you'll start making it. And then, so what are you testing for with the pregnancy test? HCG, which we talked about last week. So you're testing your urine for the HCG that's being produced by the blastula. So that's kind of the review stuff. Does that make sense? Okay, so now, doctor's going to check Amber for some things in her urine. Wow, let's review for your final. This is what your final might be like. Oh, you left your pencil. Your pen? Just write with blood. There you go. Real men prick their finger and bleed. All right. So, she is getting bloated, swollen, and more BP. And I want a non-reproductive hormone that does all that from 232.
That's too tough for me. I need that.
Starts with A. Aldosterone. Very good review. ADH partially, but we'll do aldosterone. So remind me from the exam you just took, aldosterone's job is to do what? Reabsorb salt. So if you have aldosterone going up, you're going to have more salt being retained. And what does salt attract? Water in the ECF, so hence you're going to get bloating, edema, and blood pressure, right? So making you saltier. Notice the doctor says you do not have protein in your pee. What say ye, good or bad?
Good.
That is good. What would it mean if there was protein in the pee?
Filtering it.
Why shouldn't there be protein in pee? It's too big, right? So the logic is, even though your pressure's going up, you're not forcing big things through the nephrons. So this is a good sign. That means you're not damaging your nephrons. Does that make sense?
Except you were saying that non-pathological for protein in the urine, that it could be pregnancy?
Yes, and that's the logic behind it. So as your pressure goes up while pregnant, you could end up with protein spilling through, but it's not a disease. Well, pregnancy kind of is, in a way. So, what would be a concern? If you had something in your pee, what might a doctor be nervous about? So list some things that shouldn't be in urine.
Blood.
Blood is one of them. Let's use green for blood. So tell me why blood would be a concern in pee. Same as protein. It's too big. It should not be in there. When something else that should not be in your urine. Glucose. Why might glucose be a concern? Diabetes, right? You should be reabsorbing it. If I'm not, therefore it spills over, I have too much sugar. So possibly gestational diabetes. What would go along with glucose? If you really were diabetic, what else would be in the pee? Ketones might be in there, because I'm burning fat, which we'll learn today why. What else might be in pee that would be problematic? White blood cells. Because they mean that we're infected. So the good review for urinary system, small stuff only, this would be bad. Okay, so then we're going to go down to Amber's moral gymnastics here. She's trying to somehow convince herself nothing's really there. Well, let's educate her, shall we? Week 9, what is in there by week 9? Everything is organs have formed. Right? Because organogenesis is week 3 to 8. So what do we call you at week 9? Fetus. Because you're a fetus. has to come to grips with that reality. All right? So hence week 9, you've made your organs, internal major organs, therefore your fetus. Make sense? Okay, so that should be reviewed. Now comes the new stuff. Number 8. We're going to have to figure out reproductive hormones. That's going to happen during pregnancy, which I haven't taught you yet. To teach those to you, I have to teach you a different body part that explains this graph. You saw this last week, right? Nod your heads. Okay, we learned HCG, human coronary gonadotropin. My question is, this went down, but these went up. Where are those coming from? The placenta. Tonight we are going to talk about your placenta. So we're going to take a detour down the placenta land. What is a placenta? Your mom taught you what it was. What was it?
An organ that takes care of the baby.
Organ that takes care of baby. I like that. Takes care of baby. Okay, let's try to flesh that out a little more sciencey sounding. How does it take care of your baby?
Supplies and nutrients.
Supplies nutrients. We're going to say for this class, nutrient exchange. So the placenta is where you have nutrient exchange as one function. So I'm going to show you a picture of a placenta, and then we're going to zoom in on this concept of placental nutrient exchange. Like that. Give me a second here. I've lost my way. So, did I show you this picture last week?
Yes.
Yes, no? All right. So here you are, nice and cute. You have organs. This big lump outside of you, that's the placenta. That's the thing you're going to basically grow into mom and steal her life, right? So if I drew that, there you are, right? I can't draw. I really can't. I have no skills. No skills at all. That's why I became a teacher. So we're zooming in on that. That's the placenta, right? Somebody asked me once, this is a boy or a girl. I have no idea. Right? So this is a close-up of where I want you to look. So this reddish, pinky color, whatever you call it, that's mom, maternal. Blue and red, that's fetal, umbilical. So this is babies. This is mom's uterus. What do you notice about that? What do you see in there? Let's look up close.
Capillary.
I see capillaries, good. What's the job of capillaries in 232?
Filtration.
Filtration and exchange and diffusion, right? So if we follow the arrows, here's blood from baby going to placenta. Why is it turning red? It's blue, why is it red? Where's it getting it from? From mom. So we diffuse or exchange from mom. Oxygen, there's more oxygen in mom's uterus than in me. So it goes in from her uterus to there. I turn red, head back to me, right? And also I could do waste. So baby has more waste than mom. Diffusion says it leaves, right? So it's an exchange organ or diffusion organ. But I want you to notice one thing. Notice that they're actually not connected. Notice there's a space all the way around. Why aren't they connected?
They're not the same blood type.
Good answer. So you're not the same blood type as mom. Why else would you not want to be connected directly to your uterus?
Baby's non-self.
Baby's non-self, so immune problem, right? Your body would attack it. Yeah, give birth, right? Your uterus comes out with baby. That's real birth control. You died, right? So if you think about it, a lot of people say that you and baby are plumbed together, but you're not. It's not like a hydraulic cylinder on my tractor. You're not connected in any way. You're actually two separate beings. There's no direct connection between you and the mom. There's actually separate blood, separate location. The only trick is you get close enough to exchange. We call it interdigitating. It means your fingers go together. So even though you're sharing stuff, you're not connected in any way. So a common misconception people have is that baby's blood's going through your veins. No. Baby's blood's in baby's veins, but not yours. Right? So even though you're exchanging, you're not actually together. So I'm going to show you an animation of that placental concept here. As soon as I can figure out what I did with it. I'm going to make it as loud as I can and keep my ear on. Oh goodness, I lost it. Go back. Back. They're having a party, it sounds like.
The thing on the walls over this.
Yeah. Ah! Yeah. Great.
people have mistaken ideas about how a growing embryo eats and breathes in the uterus. From the earliest stages of its development, the growing embryo requires nutrition and oxygen, and a disposal system for the waste products of its own metabolism. All of this is accomplished by the placenta, which allows the growing embryo to eat and breathe while in the mother's uterus. To get some perspective on how the placenta began, let's go back to day 8. This hollow ball of cells moving through the uterus is the blastocyst, searching for an implantation
Week
site.
1 implant, right? That's the logic here.
You see its outer layer beginning to extend out and implant in the uterine lining, searching for the uterine blood vessels that would nourish it throughout the pregnancy.
Sneaky.
As it went deeper, a single layer of cells from the mother's uterine lining surrounded it so that it would be protected from harm. On day 9, as it grew larger and more complex, the blastocyst became an embryo.
Not really.
Here it's about the size of a pinhead. Also, on day 9, the outer layer of the embryo developed spaces called lacunae. The lacunae filled up with blood from the mother's uterine lining. On day 13, small projections from the embryo's chorionic layer reached out into the uterine lining. The chorionic layer is one of the membranes that surround the embryo and help it implant. On days 15 through 21, blood vessels began to form beneath this chorionic layer. Around day 21, the embryo's bloodstream and the mother's bloodstream were in such close contact that nutrients and oxygen could cross from mother to embryo. This was how the embryo first got its food and air from the mother. And
Write that down. So what age are you when you have a placenta?
3 weeks.
3 weeks. So week 3. Week 3. So remind me from last week, what's happening also at week 3?
That's relation.
Gas relation is finished, and we're now doing what? That's organogenesis. You're an embryo, right? So for your notes in this class, when you become an embryo, you have a placenta. You're going to start exchanging with mom. So those two we're going to consider together. So the embryonic period is your placental period for this class. So I'm going to start exchanging with mom basically when I become an embryo. All right? So week 3, onward. So week 3-ish. Embryo. Let's keep going. We're not done yet.
let's magnify this area so you can see what we're talking about.
Cool.
Here, you see a vein and an artery from the embryo in close contact with the blood in the mother's uterine lining.
Right.
Inside the blood vessels, you can also see red blood cells, which carry oxygen. The two blood streams are separated by a thin collection of tissues in the placenta called the blood barrier.
That's that concept we've been talking about in 232 about the blood-brain barrier, the nephron blood barrier, testis barrier. You don't want the two actually coming together. That's a bad idea. So if you think about your nephron, right, blood cells can't get into your pee because they're too big. The same logic here. Mom's blood cells and my blood cells can't really get together. So they're separated by the barrier. That means only small things can exchange, right? So what things do you expect to exchange in this placenta? We mentioned some. What are some things you might exchange? Gases. Gases are small. So things we're going to exchange are gases. What else? Glucose. Sugar is small. What else might you exchange that could be small? What is it? Amino acids. Very good. Or small peptides. How about water?
Yeah.
Yep. How about salts?
Yes.
Yep. Some hormones. Even though they're proteins, some hormones. Right? So we expect things just like a nephron. Small stuff we should expect to exchange between mom and baby. Big things like RBCs should not be able to cross. That's the logic of this system. So blood shouldn't mix, other things should. All right? Let's keep going. There you go.
And allows waste products to pass from the embryo back to the mother. The blood barrier also prevents many large or potentially harmful particles from entering the embryo's bloodstream. Notice that the red blood cells do not cross from the mother's bloodstream to the embryos. You may be wondering how a mother's blood cells could be harmful to her growing baby, and why it's important to keep the two bloodstreams separate.
I can think of that.
If the mother's blood type is positive and her embryo's blood type is negative, then the mother's blood cells would treat the embryo as an invading foreign organism and
Actually, if you remember 232, they got that backwards, right?
Yeah.
It's a negative mom with a positive baby. But the idea is correct, right? That you mix and match blood. But they have it reversed. Wrong them. The internet's always right. Okay. So anyway.
Now you can see why the placenta and its blood barrier are important for supplying the growing embryo with nutrition and oxygen, removing its waste products, and preventing harmful substances from getting into its bloodstream.
All right. So that's our placenta. That's the thing exchanging all these things. So, go back to this picture. So whatever is in mom's body that's small, gases can enter baby, and baby can pass back stuff that's small as well. Make sense? Okay, but there's something else. So if you think about this placenta, and you go back to this picture here that I showed you last week, which I lost somehow, right here, boom. What else does the placenta do besides exchange? Tell me where those estrogen and progesterones came from? The placenta. So the placenta also does hormones. So in addition to being a nutrient exchange, it makes hormones. It's an endocrine organ. So we're going to learn the hormones that the placenta makes in addition to doing nutrients. So over here, we're going to make a list of 5 hormones that thou shalt know, because thou shalt know them. Right? So over here are placental hormones. So all of these are made by the placenta in addition to its job. We're going to make a list of them as I go through an animation. So we're going to explain that graph. All right? So it's formally, the placenta is a temporary endocrine organ, which freaks people out. Right? Go here.
Estrogens increase uterine blood.
All right, so to get your bearings on this animation, this is the placenta. Baby's over there, mom's over here. And so this is representing the barrier between mom and baby. Okay? So, here are some hormones made by the
Thereby
placenta.
maintaining the endometrium during pregnancy. High levels of both estrogen and progesterone inhibit the formation of breast milk. Progesterone inhibits myometrial contractions of the uterus to prevent premature birth.
All right, so our first 2 hormones, those 2. Number 1 and number 2. Blah, blah. What is that? Placental estrogen, number 1, and placental progesterone. Can anyone guess why I'm writing placental each time?
Because it's the
Because they're from the placenta. So remember, like our enzymes, you name the source. So there's ovarian estrogen, which we talked about last week. Now this is called placental. It just means it's from the placenta. Same hormone, different source. So from that animation, we'll lump them together. What do these do? So let's review from last week. What do estrogen and progesterones do to your uterus?
Keep the lining.
So maintain the uterus. So they keep your uterus nice and thick, nice and bloody. They calm them, like crazed natives. Right? Keeps your uterus from spazzing in a nice way. Right? So the goal is to keep your uterus thick, keep it bloody, keep it calm, and maintain the pregnancy. So the placenta now is telling your uterus to calm down. That came out wrong. All right. Yes?
So the placenta is part of the endometrium as well, or the endometrium is part of the placenta?
These cells are placental, fetal. This part's considered maternal. So together, both of them, the endometrium becomes part of the placenta, but not in a direct way, just that area. So formally, I can't make it bigger, but if we follow my mouse, these blood vessels and cells here, that's babies, and the part sticking into his mom, so these together form the placenta.
Well, how come it's showing?
Right, the endometrial part, they just kind of overlap, but technically the placenta ends about here.
Okay.
It doesn't go all the way through. They're showing that's in the endometrial layer. Right? So let's keep going. Click the placenta. Boom.
Relaxin inhibits myometrial contractions of the uterus. It also contributes to preparations for birth by stimulating increased flexibility of the symphysis pubis.
All right, hormone number 3, placental relaxin. Tell me what it does from this animation. It relaxes what? It relaxes cartilage. This actually we talked about 231, if you remember way back then. So give me some locations of cartilages you may want to relax
Pubic
while pregnant.
symphysis.
The pubic symphysis. Why would you want your pubic symphysis to relax?
Get more room for the baby.
So a pumpkin is going to come out there, right? It's kind of helpful if you can make things get bigger. So what other cartilages might you relax besides your pubic bones? Women complain about this when they're pregnant.
Your back.
Like,
Your back, so your vertebrae, your intervertebral discs, right? Your feet,
hips.
your hips, your joints. Any place there's cartilage, you're going to weaken the cartilage. Vertebrae, pubic bones, everything. Make room for baby. All right? So let's keep going. So we have estrogen, progesterone, and relaxin, all made by the endometrium. I'm sorry, the placenta. Click on the placenta. I love this one.
Human chorionic somatomammotropin
Good Lord. Okay. That's not the name I grew up with and learned in college, nor is it, there's another synonym which is called lactogen, which you can use, but the formal name is somatomammotropin. Body breast grower. It's bizarre.
The S enhances maternal breast growth by increasing protein synthesis. Human chorionic somatomammotropin, also called human placental lactogen, prepares the mammary glands for lactation. Human chorionic somatomammotropin increases the use of fatty acids for maternal production of ATP, leaving more glucose available for the fetus. This hormone also acts to make maternal cells insulin resistant, reducing the use of glucose by the mother's cells. As such, more glucose remains in the maternal blood and becomes available for the fetus.
All right, so I'm going to use the lactogen word just because I don't want to write out somatomammotropin all the time. So let's see, it increases breast activity. In the farm we call this priming the pump. I don't know if any of you would get that logic, right? It primes the pump, makes your boobs grow. What else does it do? Let's see. It increases fat use by mom. But why is mom burning fats? Why is she not burning sugar?
Because she's keeping sugar.
Because it's keeping sugar out of her cells. So it decreases mom's sugar, therefore it increases blood sugar. You're not burning it, therefore it stays in your blood. Why would you want more blood sugar, say ye?
It's for energy.
Whose energy?
Baby.
The baby. So at some point in your mind, you're thinking, really the placenta is taking over your body, right? You're going to maintain your uterus whether you like it or not. Your pelvic bones are going to change whether you like it or not. And now your blood sugar is going up whether you like it or not, because the goal of the placenta is to keep the baby alive, not you. Right? You've done your job, you've gestated. So the placenta now is telling the woman's body to become diabetic, so the baby gets the sugar and you don't. That's where gestational diabetes rolls in, is your body cannot process sugar because baby gets the sugar, you don't get the sugar. So you have to burn fats instead by boosting ketones, right?
Does everyone get gestational diabetes?
No. It's kind of a combination of things, but part of it's diet, and part of it is if you're already overweight, you tend to get more gestational diabetes because these levels are very high. And so this just makes it higher. So women in the U.S. tend to be gestational diabetic because you're already operating with more body fat, whatever.
There's a threshold,
Yes.
and if you're already high enough,
Then it just puts
chances
you
of-
over,
okay.
right. So you're going to be slightly diabetic anyway, but if you're already prone to that, it makes it worse. So the baby is getting the milk ready to go and telling mom, don't you dare use my sugar. Cool. All from the placenta. Let's keep going. There's more. One more.
Corticotropin releasing hormone from the placenta stimulates the fetal anterior pituitary gland to secrete adrenocorticotropic hormone.
Boom. This one has many steps, so we'll put it up. So first one, CRH is the next one. Placental CRH, which is fine as an abbreviation. Cortisol releasing hormone. All right. CRH causes what to go up? ACTH to go up, right? And from last term, what does ACTH cause to go up? I can change your grade a year after you take a class. If you don't answer me, I'm going to fail you all. Turns on your adrenal cortex, which turns on your bell-ended corticoid.
Steroids.
The steroid hormones. That's pulling teeth. For example, cortisol.
Please get this over.
Right. I didn't teach you anything there. Right. So we expect cortisol, cortisone, glucocorticoids to decline. So if I turn on CRH, I'm going to turn on the adrenal cortex and get more cortisol. Let's figure out what that does. Does it do what you think it does? Here we go.
ETH. ACTH stimulates the fetal adrenal gland to secrete cortisol, which is required for fetal lung maturation and the production of surfactant before birth.
So this turns on the lungs.
Placental corticotropin releasing hormone levels increase greatly toward the end of the pregnancy and stimulate the fetus and the placenta to produce more estrogens. Increased levels of estrogen act as a timer for birth and preparation for lactation.
So I made cortisol go up, which makes the lungs of baby increase, lung development, and it increases estrogen. So two things: grow lungs and put in. Why do you want estrogen if you're an embryo? Right, for this. So it's also doing a double hit of estrogen.
So is it going to the embryos, anterior pituitary, or moms?
It goes to babies for this one. So it's fetal ACTH, fetal cortisol. The adrenal gland also produces estrogens in the fetus, so you get a double hit. Some of this actually goes into mom, and it causes hers to upregulate as well. But mostly this is fetal effect. So we get all done. We have 5 hormones: estrogen, progesterone, relaxin, laxogen, and CRH, all made by the placenta, making the uterus happy, removing your cartilages, growing breasts, increasing sugar, growing lungs, and raising estrogen. These are all the hormones to maintain the pregnancy. Made by who? All placental. So every hormone of pregnancy is basically a placental hormone. It takes over the job. All right. So to prove I'm not making this up much, let me show you this graph again. So remember, HCG goes down, but these hormones keep going up. Why? Because the placenta is the one making them. Right? It's the one running the pregnancy, running the show. You're just a vessel for your placenta. Okay? Make sense? That's the logic of this one. So let's go back to here. Click on.
Just prior to birth, high levels of placental corticotropin releasing hormone
CRH.
stimulate the production of more estrogen. As the level of estrogen surpasses that of progesterone, uterine contractions are no longer suppressed.
Remember, progesterone's job is to calm the uterus. The uterus is getting less calm. That's how we say it. So my uterus is going to get more sensitive. Your uterus.
Levels of estrogen cause gap junctions to form in the smooth muscle cells of the myometrium, allowing the muscle cells to work in a coordinated fashion during labor. High levels of estrogen cause an increase of oxytocin receptors within the uterine muscle fibers. Since the oxytocin stimulates myometrial contractions, the increase in oxytocin receptors triggers the uterine muscle fibers to contract. The overall result of increased estrogen and oxytocin is stronger contractions as the time for birth nears.
All right, so as these levels keep climbing, the body will eventually become a birth cascade. Before we do that, though, let's go back to Amber here. So we did our hormones. There they are. Thou shalt know those 5. They're all made the same place. They have different jobs. Now we're going to figure out what they're doing to Amber's body. So let's review. Lordosis from 231. What was lordosis? Sway back, right? Leaning like this. Why do pregnant women have to lean backwards and waddle? They'll fall forward. Why would they fall forward?
Center of gravity.
Center of gravity. So let me show you a picture here. You know, honestly, as a male, I find the uterus a fascinating thing that can do this, right? Your uterus, someone's uterus, is the palm of your hand when you're not pregnant. It's your abdominal cavity when you are. You can do that, survive it, and voluntarily want to do it again. To me, that's fascinating, right? If this were your head, you'd blow up, right? So your uterus can get huge, right? Because that guy's in there, right? So think about that. You have an 8-pound baby 2 feet in front of where your back used to be. So you want to fall forward. So how do you stop from falling forward? To lean back to put the baby over your knees. Don't ever do this, but if you ever take a 9-month-along woman and hold her straight up, she'll fall forward. She'll kill you and no jury would ever convict her, right? Because the weight wants to pull you forward. I've never done that. I'm a friend, right? But this is the idea. So balance. You have too much weight, so you have to lean backwards to do that. Right? So that's the idea of lordosis, is the weight change. So let's try this one. Breast size. Why are they getting bigger? It's probably over there somewhere. Lactogen or somatomamotropin, right? Number 4. Your boobs grow because the pump's getting turned on. So you're not actually making milk yet, but you're preparing the glands, they're growing, they're doing mitosis, so you're getting more breast activity. Okay, harder one. Areola are getting darker. Well, so the baby can find them. Those are the bullseyes, we call them. But why? Why are they getting darker? Why do you get the linea nigra?
Increased blood flow.
Increased blood flow. One thing I'm going to add up here, which I didn't add before, but I'm going to add now, is that's an additional thing of estrogen. Estrogen also increases blood flow to skin. So what do we always say about pregnant women? You have such a what? Glow. That's the logic of the glow. Is you're getting more blood to the skin radiates more because the higher estrogen levels also cause blood to go to your nipples and your lips and your nose and your labia, all sorts of places. Tell me about the urinary inconsistency and incontinency.
Baby's pushing on the bladder.
Let's find that. Let's find baby somewhere right here. Okay, there's a bladder here. Can you find it? No. That thing there used to be a bladder. Someone's head is in it. So you can't store urine, so what do? Pee all the time, right? So basically it's a problem with you basically don't have storage of your urine. So that's the incontinency urgency. Constipation, can you tell me why you might be constipated? Let's find your rectum. Where is it? Where did it used to be? That used to be it. That's now someone's head. So someone's head's in your rectum. So go back to digestive system. If there's a blockage in your colon, you absorb more water, hence harder to push, hence constipation. All right? So the baby is physically trapping the urine, physically trapping your poop. So you gotta be nice to pregnant people, really. Okay, widening of your feet, pelvis, and hips. It's over there. Relaxin is the answer because it relaxes your joints. Your preparation for childbirth relaxes all the cartilaginous joints. So where there's trivia, your foot size goes up a half a size after pregnancy. Your hips go up 1 inch after pregnancy on average. Because they widen and then they refuse. So don't blame me, I'm just a messenger. Number of RBCs. Why would RBCs go up?
Oxygenation.
It's on the board up here, actually. So let's see, so what gases are you giving baby again? O2. So mom's oxygen is going to go down, right, as baby sucks oxygen in. So from last term, if your oxygen goes down, you're going to make more of a hormone. So it's an E, ends with an O. EPO, and what does EPO do?
Red blood cell maker.
So mom's body thinks she's living in Denver for 9 months. So during the pregnancy, baby's stealing your oxygen. It drops below normal. Your body compensates by cranking out more blood. All at 232. So it's just like losing oxygen. Make sense? Let's do nausea and heartburn. Why? Why are pregnant women usually, besides the morning sickness, which is not what this is referring to, looking at this picture, can you guess where your stomach used to be?
Up in your lungs.
Out here. Where is it now?
In your diaphragm.
Somewhere in your throat, right? So what would happen if you push on your stomach more often?
Puke.
You're going to puke because the acids are going to hit that sphincter. Remember, for reviewing your spinal, all those sphincters. So if I push on your sphincter, like in this picture, your stomach's now crammed somewhere up by your lungs. That makes it hard to store food. So less room, more acid, more sphincter. Worthless trivia, relaxin also causes your sphincters to loosen slightly, which is why you tend to get more acid reflux and various other embarrassing things, because your sphincters also relax, just so you know. So let's keep going. Hair and nail growth. Why do you get better hair and better skin when you're pregnant? That's the blood flow thing. You're feeding your hair more nutrients. You're feeding your hair more. And what do pregnant women complain about after the baby's out? They go up and they pull out hair and they cry and hate me, right? Well, it's because you're losing the hair because you're losing the blood flow. So your hair falls out because you're not feeding it anymore. So it's sad. I have a lot of respect for pregnant women. That's hard to go through. Okay, libido changes. Why might your sex drive be different?
Your estrogen and progesterone levels are.
Because your estrogen and progesterone levels are all over the map, right? So as those climb, those are sex hormones. Sex hormones make you sexy. So you're going to get changes in libido and sex drive. Let's try the breathing rate one. Can anyone guess why you're going to breathe more often but shallow?
You push your diaphragm down to
Yes.
breathe in more.
Remember breathing and review for your final. To breathe, I have to lower my diaphragm. Somebody's foot's in the way. So it's hard to lower your diaphragm. So you're going to have less breathing and have to compensate by breathing more often. Right? In addition to your posture. Good. Blood flow to skin we did. Mask of pregnancy is the estrogen. So when Amber gets done being pregnant, those hormones have told her body to have more blood flow, move your pelvis around, turn on your breasts, get all this stuff rolling. Right? Make sense? Okay. So since some of you are going to be labor and delivery nurses, you're supposed to know, according to PCC, these words and what they mean in terms of your future career. We have engagement, the show, effacement, water breaking, all that. So I'm going to walk you through some of these terms so you understand what we're talking about. So to do that, I'm going to let an animation help me. Back to the beginning here. Look at that. Give me a second. Bring on the screen.
Memory's full. Damn it. I have all day and be.
Inside a pregnant woman's uterus is an amniotic sac, which contains amniotic fluid and the growing fetus. The amniotic fluid is important for several reasons. It helps keep the baby warm, and because his body parts are growing so fast, the fluid provides lubrication that keeps them from growing together. In some cases, fingers and toes can become webbed as a result of not enough amniotic fluid circulating in the uterus. The amniotic fluid also lets the baby move easily, so he can exercise his muscles and strengthen his bones before he's born. In addition, it acts like a liquid shock absorber for the baby by distributing any force that may push on the mother's uterus. Even sex won't hurt the baby. Amniotic fluid is 98% water and 2% salts and cells from the baby. Until the fetal kidneys start working during month 4, amniotic fluid is made by the mother's body. But after month 4, the little guy started making his contribution to the amniotic fluid by urinating in it. You heard right. It may not sound appealing to us, but the urine in the amniotic sac is completely harmless to the baby. The baby swallows amniotic fluid, which then passes through his digestive system, into his kidneys, and back out again to the amniotic sac as urine. In this way, he can practice using his digestive and urinary systems before he's even born. In fact, doctors can tell by the amount of amniotic fluid whether the baby has difficulty with his swallowing reflex. By the time he's born, he will consume up to 13 ounces of amniotic fluid a day.
There's Jimmy for a party, huh? All right. I'll just show you that to show you the word amnion. So amnion, amniotic cavity, that's the sac you're in, the bag you're in, the sauna you're in. That's to prepare you for the next couple words we're going to use. So we need to do this one here.
One of the first signs of labor starting is the appearance of a mucus plug, or what is sometimes called a bloody show. The bloody show is the discharge of a small amount of pinkish mucus that form the barrier between the uterus and vagina during pregnancy. Shortly after the bloody show, another important event occurs. The amniotic sac ruptures, and amniotic fluid begins to trickle out of the uterus and vagina. For some women, it can actually gush out in a stream. The rupturing of the amniotic sac, which surrounds and protects the baby, is commonly referred to as the water breaking. The combination of contractions, the bloody show, and water breaking
British.
indicates the first phase of labor starting.
All right, so let's go back to this. So let's start writing some of the words we've learned in these fascinating animations. So we have learned water breaking or water broke. What water is breaking? The amniotic sac, that hot tub you're living in. So water breaking is the amniotic cavity, the amnion breaking or rupturing. You can say amnion, amniotic cavity, amniotic sac. There's a lot of words, but the amnion is the hot tub you're living in. So your water breaks, that's one. So what other word do we have? The bloody show. What was the bloody? That sounds so bizarre.
The mucus plug.
The mucus plug. And where's that mucus plug normally? In the cervix. It dislodges. So it starts coming out because your cervix is going to expand. Yeah.
I was at my work charting one day and I saw that as an option for one of the, like...
Bloody show, check mark.
I was so confused.
Yeah, that's an odd, you think they come up with a different way to say it than
Yeah.
bloody show, right? But that's what they mean. So the plug that holds the uterus closed, this is the cervix's gatekeeper, comes out, and it can actually come out like a cork or come out as a kind of stringy stuff. That's the show, right? So now we gotta learn these other words for you future nursing professionals. Engagement. Anyone know what Yes.
So does the show allow the fluid to come out?
Yes. You have to go through the show to get the fluid under normal conditions.
But just because you have the show doesn't mean that you're going to have.
Correct.
Okay.
So you can have the show and then the water can break way later. The water has to break for the baby to come out, but those two can be separated by time. So you can have the show really early and the water breaking really late.
Like weeks apart, or?
No.
No, but like day apart kind of thing, labor time apart.
Some babies can be born in the sac too.
They can. That's not the norm, right? I remember. So for my son's birth mom, this world's different, but when we adopted him, we got him at birth, but I was the birth coach for the birth mom. I wasn't planning on being the birth coach. I was at the hospital and they say, we need you in here so she can throw up on you. So I was. Yeah, but her water broke like one day and it was the second day when she actually gave birth. So it was almost like a day difference. So it kind of, I was not planning on that event, right? So I was just there to see the attorney. Here, catch your vomit. All right.
So is the mucus plug just strengthening the cervix?
Right. It's
Okay.
basically another barrier. So the cervix itself is like a sphincter closed. You pack it basically with mucus.
It's like
There,
the
nothing's
grout
getting in.
in the title.
Right? So let's do those other words. To do that, we have to watch this.
In the birth of a child, a number of changes occur in the position of the fetal head as it descends through the bony and narrow birth canal. These changes, called the cardinal movements or mechanisms of labor, are engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion.
Now you don't have to know them all.
The movements apply to a fetus that is presenting in a vertex presentation, an optimal presentation in which the fetal head is fully flexed. This is in contrast to other cephalic presentations, in which the head shows incomplete flexion or even full extension. Engagement occurs when the widest diameter of the fetal presenting part, the head in this case, has passed through the pelvic inlet. Note how the fetal head enters the pelvic inlet, which is widest from side to side. Descent, the next stage, is the progression of the fetal head into the maternal pelvis. The degree of fetal descent is measured by stations. Station refers to the level of the presenting part in relation to the maternal ischial spines.
which represent the narrowest diameter through which the fetus must pass. If the head is at station 0, at the level of the ischial spines, engagement has occurred. Positive numbers indicate that the presenting part of the fetus has descended past the ischial spines. Flexion occurs as the fetal head descends and comes into contact with the soft tissues of the pelvis, the muscles of the maternal pelvic floor, and the cervix. The resistance encountered with these structures causes the fetal chin to flex downward onto the chest. This position allows the smallest fetal diameters to enter the maternal pelvis. As the fetal head continues to descend, it must rotate to accommodate changes in the width of the pelvic opening. While the pelvic inlet was widest side to side, further down, the pelvic cavity is widest front to back. The next stage, extension, is underway. As the fetal head passes under the maternal symphysis pubis, it meets with resistance from the pelvic floor. The head pivots and extends with each maternal pushing effort. The head is born in extension, with the face directed toward the rectum. The next stage is external rotation. After the head is delivered in the extended position, it rotates briefly toward the position it occupied earlier in the pelvic inlet, realigning the head with the long axis of the body. This movement is termed restitution. As restitution continues, the shoulders align in the anteroposterior diameter, causing the head to continue to turn farther to one side. The fetal trunk moves through the pelvis with the anterior shoulders descending first. In the next stage, expulsion, maternal pushing efforts bring the anterior shoulder under the symphysis pubis. Lateral flexion of the shoulder and head occurs, and the anterior, then posterior shoulder appears. Once the shoulders are delivered, the rest of the body quickly follows.
Looks so easy, doesn't it?
Yeah.
All right, yeah. Let's go back to our words. Got a couple on there we need. Oh, what did you do? So, engagement. What was engagement?
Head in the.
All right, so the head descends into the pelvis. So the baby is dropping or engaging the pelvis, sometimes called the drop, you may hear people say, but baby basically is engaged. You're going down the pelvis. You're getting closer to the outlet. They didn't mention these two words, but we can figure them out. What does effacement and dilation mean?
Of the cervix.
Of the cervix. So the cervix gets thinner, thins, and opens. So you need to open the gate and make the gate thinner. That's the effacement and dilation stage. Crowning.
Baby's head.
Baby's head is coming out. Yes.
Okay, this probably sounds like a dumb question,
Hit me with it.
but and during your last month of pregnancy, you begin to have a lot of Braxton Hicks.
Yes.
So when that happens, does your progesterone and estrogen level begin to come down because you're actually getting into contraction?
Kind of. So what happens for Braxton Hicks is the uterus is uploading receptors, it's upregulating, so it's more sensitive to the oxytocin. So the brain is starting to release a little bit of oxytocin. The progesterone is not high enough to calm it all the way, so you're getting these preliminary contractions. But then when birth hits, basically it upregulates everything, drops all the inhibition and goes. Yeah, so it's like a mini situation. But the progesterone's still high enough. It's just the upregulating receptors. So again, those words? Okay, so now we're going to get the baby out of there. We've learned these steps. Now we actually have to get the baby out of there. So now, let's go to here. Yeah. Back to this one here. Back going.
Like other just prior to birth, high levels of placental corticotropin-releasing hormone stimulate the production of more estrogen. As the level of estrogen surpasses that of progesterone, uterine contractions are no longer suppressed. High levels of estrogen cause gap junctions to form in the smooth muscle cells of the myometrium, allowing the muscle cells to work in a coordinated fashion during labor. High levels of estrogen cause an increase of oxytocin receptors within the uterine muscle fibers. Since the oxytocin stimulates myometrial contractions, the increase in oxytocin receptors triggers the uterine muscle fibers to contract. The overall result of increased estrogen and oxytocin is stronger contractions as the time for birth nears.
So we've this was already playing once, but we're going to go back through it again now, steps of birth. So estrogen is going up, as we did over there. That causes you to get more oxytocin receptors on the uterine muscle. So remind me from 232 what oxytocin does. Contraction. So I'm listening better to contract, is what the muscles do. They're hearing it more. Yes?
Why does estrogen do that? I'm like,
Magic?
okay.
Right.
But does it do it any other time besides this?
Not under normal conditions. Normal conditions, your uterus should actually downregulate oxytocin, except when you're menstruating, the cramps, those kind of things. But during pregnancy, actually, your uterus downregulates because you don't want to start labor before the baby's 9 months along. But somehow the uterus changes its viewpoint and starts to upload oxytocin late in pregnancy, month 9. So it goes from being a quiet uterus to being a listening uterus, and then it goes up. So why? Who knows, right? So let's click on the uterus. Good.
Like other placental hormones, relaxin levels rise during pregnancy. Relaxin helps to dilate the cervix and increases the flexibility of the maternal symphysis pubis. The overall result is to allow expansion of bony pelvis to make more room for the delivering fetus.
So when you start this labor process, estrogen goes up, the fetus begins to pressure the cervix. I'm starting to squeeze your cervix, right? So what do you think a cervix is going to do when there's a baby pushing on it? Not yet. It's going to send signals. So the cervix signals the brain.
What did you?
Yeah, no, it's going to. So the cervix signals the brain, specifically the hypothalamus. So the cervix is saying, hey, by the way, there's a baby pushing on me. Great. So remember what your hypothalamus is going to do. Makes oxytocin. Remember, it's a posterior pituitary released hormone. So I click on the uterus. Boom.
Labor preceding childbirth is an excellent example of a positive feedback loop that strengthens or intensifies the controlled condition. The stimulus that starts the cycle is contractions of the uterus that moves the baby's head into the cervix. When the baby reaches the cervix becomes distended or stretched. Receptor cells detect the stretch and change in the controlled condition of the cervix and send impulse signals to the brain. The impulses received from the nerves in the cervix trigger neurosecretory cells in the hypothalamus to secrete and release the hormone oxytocin. Oxytocin diffuses into the blood capillaries of the pituitary gland and is transported to the uterus. Oxytocin stimulates the smooth muscle tissue of the uterine wall to contract more forcefully. These more forceful contractions push the baby further into the birth canal, stretching the cervix more and triggering the stretch receptors to send more impulses to the hypothalamus. The self-amplifying nature of the positive feedback loop is repeated over and over with increasing intensity until the baby is born. After the birth of the baby, the stretching is halted and the positive feedback loop ceases.
So baby's pushing on cervix. The brain says oxytocin. Oxytocin goes to the uterus hears it, contracts, and that's going to cause an increase in step number 2. So the fetus is going to push more, which makes more brain, more oxytocin, more contraction, which then makes more baby. So there's a positive feedback event. You get more and more. They add together. So when does this stop? Once the baby's out. So once the baby's out, there's no stretching, hence the system turns off. So birth is a positive feedback event. But we're not done yet. So we got the baby out. So this is called expulsion. Doctors love that word. When you have a baby, you're expulsing it. Doesn't that sound romantic? All right, but we're not done yet because there's something else we have to do. The placental stage. So now our next one is placental. Sounds like a party. Does that sound like a party? Yeah.
The labor process is divided into 3 stages. During the first stage, the thick cervix thins and opens to a diameter of about 10 centimeters. Amniotic membranes usually rupture during this stage. In the second stage of labor, the fetus descends through the open cervix into the vagina and under the symphysis pubis. The force of the contracting uterine muscle combines with the mother's voluntary pushing efforts to deliver the fetus from the vagina. In the third stage, the placenta is expelled and the uterus contracts upon itself, thereby preventing the mother from hemorrhaging. Click on the uterus to learn about regulation of lactation.
All right, so our last stage we're going to put as number 6. Placenta is delivered. So the placenta, remember the placenta is made by the baby. It's not yours, so you have to give it to the baby. So the baby comes out, takes the placenta with him. So what do we call that? That's usually the afterbirth part. The afterbirth is the last stage of birth because the baby comes out along with his or her placental organ. Make sense?
We're totally
partying earlier. Yeah. Some people go to college to learn, you know. All right. So do okay on the steps. So you deliver, you have contractions, you set the positive feedback system, and then you deliver the placenta. Make sense? Yes?
Why do certain people keep the placenta after the baby's born?
Because they want to. So we're distributed on a farm, right? All livestock eat their own placentas. That's just what like ruminants do. There's no reason you can't, but you know it's up to you. So some people, especially in Portland, get this idea: I want to eat my placenta. Okay, it's full of iron. That's true. The hormones that are in the placenta you actually would not get because they're protein based. You digest them as you eat it. So the idea of that you're eating your hormones back doesn't hold water. So the other argument is, well, it is somebody else's body part, right? So is it okay to eat someone else's body parts? I mean, I don't know. Can you eat an arm? So there's an ethical dimension if you're eating someone else's organs. I don't think it's a big thing. I don't want to do it, but no, some people take their placentas home. Yeah.
So if you have a cesarean section, then do you have to block the oxytocin? Do they have to give you a blocker?
Good question. I do not know.
Because
I do
so
not
I
know.
was giving
Yeah,
birth
teaching
and-
him while
and
seizing.
she
I do not know. Does anyone know if they block
engaged
oxytocin
and then I
C-section?
had to
I don't, I think it's just a spinal block.
Spinal block. I'll have to look up. I don't.
Because
Yeah.
you wouldn't want that.
Because you want mom to release some oxytocin so that she bonds with her baby.
That's true for the cuddling and also
Yeah.
for the lactation. I'll have to ask. I do not know what they do for that. Because you don't want contractions or reaching in trying to grab a baby.
Right.
I don't know. Speaking of placentas, though, we have one more concept here to learn with our placenta, which is actually on the next page of your packet, which is this picture here.
I have a question.
Yeah.
So back to what she was saying
Yeah.
about there's this thing where if you have a C-section, your baby can still be deliver itself, basically, which I think is through the contractions, but instead of going through vaginally,
Right, you just-
it just goes through the hole.
Yes.
So you think that it would need oxytocin
Yeah,
to have those contractions?
that makes
to
sense.
push it in?
I'm wondering though how much if they block any of it or keep the whole thing rolling, because when you're hard labor, I don't know if they time it. I don't know. That'd be a good project for someone to do. You don't want to do it right now. Okay, so this chart. You're supposed to understand this chart. I'm not going to ask you to memorize this chart, but this is showing the organ systems over here, weeks of gestation over there, embryo, right, 3 to 8, fetus, blah, blah. The boxes and colors tell you something. So these tell you how badly you're affected by something, because the magic T word up there, teratogen, means birth defect. So a teratogenic agent is something that can cross the placenta and cause damage. So if you ever see teratogen on a pill bottle, they mean that. It crosses the placenta, through the placenta, and then it ends up in baby, and baby ends up messed up. So the black means major mess up, missing parts, extra parts, no part, wrong part. The gray means something sort of kind of is wrong. White means no effect, right? So if you look at the picture, when are most of the boxes black? They're in the embryo period, right? Why? Why are they mostly black then and not mostly black here? You're making organogenesis. You're making organs. So the logic is that when I'm making them, I can really screw up. Once it's made, it's harder to screw it up once it's formed, right? So logic is that if I expose you to something during the embryo period, I'm going to cause more damage if I expose something in the fetal or full term. Make sense? That's the logic of this. So, number one, if I expose you to warfarin, Coumadin, rat poison, during the first trimester is roughly 12 weeks. Tell me what's going to happen if I expose a pregnant woman to Coumadin that can cross the placenta in the first 12 weeks. Give me an answer. Major abnormalities where? Darn near everything, right? Everything's going to be a black bar because you're building these parts. Therefore, the drug's going to interact with that and cause damage pretty much everywhere. That make sense? Second trimester, weeks 13 on to 24, over here. What do you see? Affect the CNS, yeah. What about the other organ systems?
Some functional.
Some functional. But notice how most of them are no longer black bars. So you expect to get less damage in the second trimester than the first, because you've already built it, and it's harder to destroy it once it's built than as you're building. That make sense? So early exposure is more damaging than later exposure. All right? To show you that I'm not making this up much, let me show you this one here.
Nutritional status of a woman before conception is important. The fertilized egg is not very susceptible to toxic agents. Any trauma at this stage will result in a termination of the pregnancy, most often unnoticed by the mother. Once the embryo attaches to the uterus wall, it will begin its growth in earnest. The cells are still not susceptible to nutritional deficiencies or other dangers from the health and lifestyle choices of the mother. The embryo continues to be susceptible to radiation-induced birth defects.
Okay, so let's figure out what he just said there. So, go back here. We're now at week 2. It says, not susceptible to something from mom. Why not?
It's not attached yet.
Right, so remember week 1 we implant, but we don't have a placenta yet, right? So mom and us are not talking. So I'm all by myself. So what mom does is irrelevant. I'm all by my lonesome. However, radiation can go right through mom into me. So that's why there's a difference here. So until I have a placenta, what mom is doing really won't cross into my bloodstream. But once I get a placenta, mom and I are sharing. So week 3, I'm going to see this change.
These include cataracts, reduced growth, skeletal defects, microphthalmia, microcephaly, and mental retardation. At 3 weeks, the embryo begins to form the rudimentary organs of the fetus. The embryo is now sensitive to nutritional inadequacies.
If you have a placenta, you and mom are sharing.
At this stage, early alcohol exposure can lead to non-viability of the fetus and spontaneous abortion, or fetal alcohol syndrome in the resulting newborn. Other risks are presented by high intakes of vitamin A, medications and prohibited drugs, and trauma. The development of the central nervous system continues for 16 weeks, so the central nervous system is at high risk throughout that period. At 4 to 5 weeks, the central nervous system, heart, limbs, eyes, and ears are all developing and readily affected by inadequate nutritional status. For the heart and limbs, risks diminish after 6 weeks. For eyes and ears, the risks continue for 8 and 9 weeks longer. After 9 weeks, some of these risks diminish. By 6 weeks, the heart is beating, the eyes and limb buds are present. This period shows high risk for major structural abnormalities to the central nervous system, eyes, ears, palate, and teeth, and moderate risk to the heart and limbs. The first trimester is the period when the fetus is most susceptible. The high risk to the palate appears to be limited from 6 to 9 weeks, while risk to the teeth and genitalia continue right through to term. At 8 weeks, the fetus is about 1 inch long. Note the lengthening of the limbs. The risks
Also notice he got the wrong word there, right?
Yeah.
8 weeks, but yeah.
at this stage are physiological defects and minor structural abnormalities. In the second trimester, undernutrition has a greater effect on the mother than on the fetus. However, hereditary diseases and prescription and recreational drugs are still a danger. At 16 weeks, the fetus is 6 inches long. Physiological defects and minor structural abnormalities are still the major forms of risk, with moderate risk to the central nervous system, eyes, teeth, and external genitalia. 26 weeks marks the end of the second trimester. During the third trimester, the fetus will gain the most weight, up to 5 or more pounds, and increase in size. A major risk during this time is premature delivery. Preterm infants have a good chance of survival if properly cared for. If undernutrition has happened, then the chance of the infant's survival goes down proportionally to the extent of undernutrition. At 38 weeks, the fetus is near birth, weighs 7 to 9 pounds, and is about 20 inches long. Two widely accepted criteria for a successful pregnancy are 1, a gestation period of longer than 37 weeks, and 2, a birth weight of more than 5.5 pounds. The longer the gestation period and the greater the birth weight, the less likely that medical problems will occur. Sound nutrition during pregnancy is insurance against problems in both of these key criteria.
So if you look at the box here, some of the lines are going to be a little different than your chart. The idea is early is red, bad, later is not so bad. Right? So if you understand how to read this chart, understand the concept. If I give you symptoms, you can figure out when something occurred, vice versa. So you have number 2 and number 3 you're going to do for me. So take your team and try to do number 2 and 3. Using this chart, calculate when this happened and what happened here.